This lecture is on the care of patients with disorders of the upper respiratory system, specifically disorders of the throat. Pharyngitis is a sore throat. It's an inflammation of the mucosal lining of the throat. It may be caused by a virus, a bacteria, a fungus, but it's usually viral. About 15% of sore throats are strep. And if left untreated, this can lead to big complications. So if people come in with a sore throat, say to the primary care office or urgent care, they will do a rapid strep screen because you always want to make sure it's strep and get it treated. Strep throat is also known as acute follicular pharyngitis, and it's caused by the strain of bacteria that is beta hemolytic strep. It can also be fungal, and you will see this a lot in patients who are being treated for something else. Long-term use of antibiotics will give you a fungal infection. Remember back in physical assessment class, the white coating in the mouth or the black furry tongue. Inhaled corticosteroids will also cause a fungal pharyngitis. So remember from pharmacy, you're teaching when you have people who have metered dose inhalers that contain corticosteroids. And also if someone is immunosuppressed, you can get a fungal infection in your mouth and throat. Laryngitis, which is an inflammation of the larynx, and it's associated with a diminished voice or hoarseness. If the pharyngitis or the infection in the oropharynx goes back down into the larynx. If it extends to the epiglottis, epiglottitis occurs, and that's another thing. Things that can cause this are GERD, because you have the reflux that comes up into your throat and causes irritation. Irritation from smoking or alcohol, other chemicals that they might inhale as an occupational hazard, overuse of their voice. How many of you have ever gotten hoarse from yelling at a sporting event or a party or a big loud gathering that you were at? It can also be a symptom of laryngeal cancer, and I bolded this because this is really important for people to know. Laryngitis that doesn't go away and that doesn't have an obvious cause should always be checked out. So symptoms of pharyngitis: dry, scratchy feeling in the back of your throat, sometimes an itchy feeling, sometimes just downright pain when you swallow. You can have a fever, it's usually mild, a headache, just general malaise, especially if it's caused by a virus. Your throat, tonsils, your palates, and your uvula may be involved and will be very red. Your tonsils and your uvula are lymphatic tissue, as you recall, and so they swell in response to the infection because they are producing a local response. You, as I mentioned, also can have dysphagia, which is pain when swallowing, even when just swallowing your own saliva. Sore throat can make you really miserable. The usual course for uncomplicated pharyngitis or laryngitis, either one, is about 3 to 10 days. The diagnosis of pharyngitis, of course, is confirmed when you look in somebody's throat and you see the redness, the swollen tonsils, and also the signs and symptoms that they're telling you about. And once again, a rapid strep screen can be done, and if they suspect strep, then they will do a culture. But a culture can take 24 to 48 hours, where a rapid strep screen will tell you immediately, and then you can get that person on the appropriate antibiotics. Treatment for a sore throat: there are lots of really good home remedies out there. Tea with lemon and honey. People use ginger a lot. Warm saline gargles are good. Throat lozenges will have maybe a local anesthetic like a benzocaine in them that will help with the pain. Lots of fluids and a mild analgesic like Tylenol or an NSAID for aches and pains, especially if it's viral. Antiseptic sprays, there's one that I can think of called Chloraseptic. They also have lozenges, and those do have the benzocaine that can provide pain relief and help you swallow more easily. If indeed it is bacterial pharyngitis or particularly strep, antibiotic therapy is required. You don't want strep to move out into your systemic circulation because the complications can be life-threatening, actually. You don't think of strep throat as something that kills you, but it could if left untreated. These things can hang on to your leaflets on your mitral valve and cause an infection there and lead to mitral valve prolapse. You can get a bacterial endocarditis from it. You can get a septic joint from it. There are a lot of different things, and also rheumatic fever, which is another complication of chronic pharyngitis, or excuse me, strep pharyngitis. And it used to be real common in the old days, like when I was a kid, and we didn't have the good diagnostics. But now with the rapid strep screen, there should really be no reason for anybody not getting checked out and getting the appropriate antibiotics. Chronic pharyngitis may require some diagnosis to figure out what the underlying cause is and figure out some appropriate therapeutic measures. So, for instance, if you have a chronic sore throat and chronic laryngitis, sometimes it's not your throat. Sometimes, as I mentioned in a couple of slides, it's reflux, and the reflux is coming up. And I don't know how many of you recall ever hearing Bill Clinton speak or were familiar with what went on during his presidency, but he was hoarse all the time, coughed all the time, and come to find out it was reflux. And they treated his reflux and got better. And it took him a long time to figure that out, by the way. The other thing is, of course, chronic laryngitis is a symptom of laryngeal cancer. So that's important to find out. Sometimes you'll get polyps on your vocal cords, and that will be a cause of chronic pharyngitis, or excuse me, laryngitis. And vocal rest is very important for that. Things like humidification and filtering of the air can be important if your throat and your nasal passages are irritated. Fungal pharyngitis is treated with an antifungal agent, and you get like you'll remember this from pharmacology, a nystatin swish and swallow, where there's a liquid that they swish around in their mouth and hold in their mouth for an extended period of time and then swallow so that it gets down to their throat. There are also nystatin or mycostatin lozenges that people suck on for fungal pharyngitis, and this can be really hard to control if you have an immunocompromised individual. So sometimes people are on this chronically. Tonsillitis is when your tonsils have chronic inflammation. There's a picture of it here on this slide with some white patches, which is exudate from the tonsils. This occurs when the filtering functions of the tonsils become overwhelmed with a bacterial or a viral infection. The infection is usually viral, but it can be bacterial from strep, staph, H. flu, and also pneumococcus. So mostly you'll look at diagnosing this with signs and symptoms. People will come in with a sore throat, fever, severe dysphagia. Their tonsils will be red and swollen and often have exudate, as is noted in this picture. They may be snoring if their adenoids are also swollen. Remember, adenoids are lymphatic tissue that are in back of your tonsils. The treatment for this, of course, is a throat culture rapid strep screen to make sure it's not strep, or to just identify the offending organism, and then appropriate antibiotic if indeed it is bacterial. Sometimes when you get chronic tonsillitis, they will have surgery. And back in my youth, getting your tonsils out was a pretty routine thing. Now they realize the importance of leaving that lymphatic tissue of your tonsils and your adenoids in place because of the immune value that they have. But if you have chronically swollen tonsils and tonsils that are actually harboring bacteria that is just a resting infection that you can't get rid of, or if there's a problem with breathing, snoring, that kind of stuff, they'll have surgery. That you can either take your tonsils out or take your tonsils and your adenoids out. Nursing management, preoperative is really no different than any other um, pre-op management, but post-operative, it's really important, again, to check for lots of swallowing, because swallowing indicates that there might be blood running down the back of their throat. Swallowing blood can cause nausea, and as I mentioned before, you do not want to throw up. When you have a nosebleed, you also don't want to throw up when you just had your tonsils out. Hydration is important. Cold fluids, popsicles, things like that are important, but you want to avoid red juice or red popsicles because you want to make sure that if they're bleeding, you can tell the blood from the popsicle stain. The other thing is that you always want to have suction at the bedside just in case they do start bleeding, to get some of that blood out of there and keep them from aspirating it. Obstructive sleep apnea is something that gets a lot more attention nowadays than it used to. It comes from muscle relaxation at the back of the throat, which allows the tongue to fall back and block the airway. So apnea, as you know, is the absence of breathing. And so what happens is the tongue obstructs the airway and you become apneic. You don't breathe for a while, and then eventually you kind of snort and gasp for breath. People who are at risk for this have a small oropharynx and some of them have a large neck. Obesity is a large, no pun intended there, risk factor for obstructive sleep apnea, or OSA as it's called. Snoring is common, and most often the sleep partners are the first to notice this and bring the person in to be diagnosed and treated. Usually what happens is the sleep partner is losing so much sleep and is so irritated they move out of the bedroom, and that is the leverage to bring the person in to get diagnosed and treated. Diagnosis is a sleep study. It can be done at home with a very small portable machine. They put ECG electrodes in a airflow monitor and pulse oximeter on you, and you wear that overnight and then take it back in, and then they analyze it. You can also go to a sleep lab and get totally wired up with an EEG and all sorts of other monitoring devices, video, audio, and then you sleep all night in the sleep lab. And that is a much better study, but most insurance companies now will just do the home studies first, and then if further studies are needed, they will do the in-lab study. Obviously, snoring is a big symptom, but there are other daytime symptoms that include fatigue, morning headaches, and difficulty concentrating. And I just want to point out to you how sleepy these people are. It's to the point where when you wake up in the morning, the first thing you do is think, when can I go back to sleep? You sit at the stop sign and you think, can I just close my eyes for a few seconds here? These are the people who sit down and can't stay awake through a TV show, much less a movie. Quite often will nod off during conversations in class. It's obvious to everybody that they're sleepy. And a lot of times there are jobs that require you to be screened for this. Air traffic controllers, any kind of bus driver, truck driver, um, pilot, ship captains. A lot of people have mandatory um, OSA screening because alertness is a very important part of those jobs. Also, um, well, no, I already said that. Okay, sorry. So treatment. One of the big treatments is weight loss because obesity puts a lot of pressure, restrictive pressure on your airway and your chest. So that's a big deal. Positional therapy. There's a thing where you can actually sew a tennis ball into the back of a t-shirt and wear that, and then that will keep you off your back because side sleeping is much less likely to have the airway obstruction than sleeping on your back. There are nifty little t-shirts that you can buy now that actually have that wedge in the back of them so that you don't sleep on your back. Continuous positive airway pressure, also known as CPAP, is one of the most common things that they use. It's a mask that's hooked up to a machine that sort of looks like a little nebulizer. And what it does is it keeps a small amount of continuous airway pressure when you exhale to try to keep those airways from being obstructed. You can also use BiPAP, which is bi-level positive airway pressure, which has pressure on inhalation and exhalation. And that's for people who have some serious desaturation issues as well as the sleep apnea. Complications, untreated sleep apnea is much more dangerous than we ever thought it was. It can contribute to hypertension, an MI, a stroke. Um, Constant fatigue can impair job performance. As we talked about earlier, drowsy driving can be very dangerous, whether or not you drive for a living, whether you're just out there on the road. Um, so there's lots of different complications. Type 2 diabetes is also on that list. And the other thing you need to know is there's a lot of scams out there to treat snoring. Sprays won't treat snoring. You can have those little operations on your uvula or whatever, and that may affect snoring, but it certainly doesn't affect sleep apnea. The newest, most expensive surgical situation that's out there is something that is an implant, and it implants in your diaphragm, and it's almost like um, a little pacemaker that causes you to breathe. And it's only used for people who fail CPAP. CPAP is definitely the therapy of choice and should always be tried before you attempt any kind of surgical intervention. Cancer of the larynx is something that is common for people who use tobacco, not just smoking, but also chewing tobacco. And it is much higher risk if you drink alcohol and use tobacco. It's an interesting interaction there. It's sometimes also called throat cancer, but it's actually laryngeal cancer. The incidence is much greater in men than in women. And the signs and symptoms are persistent hoarseness. We talked about that earlier. Throat or ear pain, interestingly enough, dyspnea, cough, and fatigue are late signs. They diagnose it with a laryngoscope, which is like a bronchoscope, only shorter, and they do a biopsy. Treatment, if it's early, is radiation or radiation and chemo. If it's late, they do surgery. They can do either a partial or a total laryngectomy, and sometimes they have to do what they call a radical neck dissection, which is a total laryngectomy, and they take the nodes, and it is quite a severe disfiguring surgery, and the person winds up with a tracheostomy. This list is from the American Cancer Society, possible signs of throat cancer. It's something that you should be aware of, and you should make sure that the people that you take care of who do use tobacco are aware of. Hoarseness lasting more than 3 weeks. A sore throat that lasts more than a couple of weeks. Consistent pain in or around the ear when swallowing, difficulty swallowing, also called dysphagia. A persistent dry cough for no known reason. If they have blood in their sputum or saliva that lasts more than a few days, and then lumps or knots on the neck indicating enlarged cervical lymph nodes. When you care for someone who is having a total or partial laryngectomy, there's a lot of preoperative teaching that goes along with it because they need to prepare for the loss of their ability to speak and breathe through their mouth and nose. This is not just a learning how to speak and a mechanical kind of thing, but this is a huge loss. There's body image issues, there's role function issues. This is a big, big deal. And so they start with communication and speech therapy preoperatively to start that process. Postoperatively, the priority is always patent airway and respiratory function. Remember ABC. So patent airway and respiratory function trumps everything here. They will have a tracheostomy. So trach care, suctioning, monitoring their secretions is important, and you need to use strict sterile technique. Semi-Fowler's position, you never lay these people flat. And coughing and deep breathing is important. They will have a lot of secretions and they're going to be coughing through a trach, and so that's going to be a very different experience for them. A lot of them will have supplemental oxygen, and you need to make sure that that oxygen has humidification so that it doesn't dry out their mucous membranes. Remember, when you breathe through your mouth and nose, you get humidified air through your nose, but you're bypassing that now, and so humidification becomes really important. Pain control. Of course, they're going to have post-op pain, but you want to be really careful in these people with respiratory depression. So communicating with them about pain level, how much to give them, is their pain relieved, and making sure that you're constantly monitoring their respirations and their oxygen saturations. You want to avoid anything that has particulate matter that's airborne. So powders, sprays, anything like that should absolutely be kept away from their fresh trach. And then, as I mentioned earlier, therapy for communication, for body image, and also there's a lot of grief here. I mean, cancer is a life-changing diagnosis, but this is more than just cancer. This is disfigurement. This is not being able to speak anymore. It's a big change. The next couple of slides illustrate different ways that people can learn to speak after a laryngectomy. So there is a little prosthesis that you can put in after the surgery that's called a transesophageal voice prosthesis, and they can learn to speak through this. In transesophageal speech, air is exhaled from the trachea into the esophagus through a little silicone prosthesis that connects the two of them. So it's almost like a little conduit. And the vibrations are generated by the lower pharynx. So how this works is speaking is possible when you divert the exhaled air through the prosthesis into the esophagus. And what that does is it temporarily occludes the trach stoma. You can do this by sealing it off with your finger or pressing on a special filter that's worn over the trach stoma. The filter that's worn over it has heat and moisture exchange properties and partially restores the lost nasal functions. And something that's interesting at one of the group homes for medically fragile children that we work with, these are very, very tiny little cylinders that go over their trach, and The nurses who take care of them call them the kids' noses. So it's just a little portable nose that you wear on your trach, and serves a lot of good functions. People who have COPD may have difficulty using transesophageal speech and may find it almost impossible to use a hands-free filter because they just don't have enough airflow to support this device. You have to be moving a lot of air in and out to create those vibrations. And if you recall, people with COPD just don't move very much air. So this may not be a good solution for them. Speech can be improved by enhancing airflow. And so what you can teach, or well, you won't do it, but speech therapists teach them to relax their throat muscles and breathe deeply, preferably using their diaphragm, which will enhance the airflow. Another way to do this is by lubricating the airway and relaxing the throat muscles by drinking water. So this is something that they get a lot of speech therapy for, and it's a process. It's very complicated, but it worked quite well. Esophageal speech does not require any special equipment, like the filter that we talked about in the previous slide. In esophageal speech, the vibrations are generated by air that is literally belched out from the esophagus, and then that is used to vibrate the pharyngeal esophageal segment. Um, it takes the longest to learn, but it has a lot of advantages, not the least of which includes the freedom from dependency on any devices. It doesn't require purchasing any equipment, and it is totally hands-free. The disadvantages, of course, include need for a lot of training. You have to speak slowly. The volume is often lower, and you depend on the function of your cricopharyngeal muscle and that pharyngeal segment. So if you have any kind of muscle damage that comes along after your laryngectomy, or if those muscles are um, damaged during the surgery or removed during the surgery, you can't do this. So speech and language pathologists help laryngectomies in learning this method. There's also lots of self-help books and tapes and stuff like this for them to practice with. So this is a good method. It just takes a while for them to get used to and to learn to do it effectively. Finally, we have speech that's generated with an artificial larynx, sometimes called an electrolarynx. This method of speaking is easily learned, and they learn it pretty quickly. It produces a strong, powerful sound, and it has a device that requires batteries and the use of one hand. It requires manual dexterity and the ability to turn the device off and on before speaking. So if you have somebody who doesn't have good manual dexterity, this may not be the choice for them. If you have listened to some of those stop smoking public service announcements and heard the lady speaking with one of these, you will recognize as sort of a computer generated sounding speech. The vibrations in this speech method are generated pneumatically by air pressure by an external battery operated vibrator. It's called an artificial larynx or an electrolarynx. And this is placed under the cheek or the chin. And it makes a buzzing vibration that reaches the throat and the mouth of the user, and then the person modifies the sound using their mouth and their tongue to articulate the speech sounds. These can be used very shortly after the laryngectomy while people are still hospitalized. And they can learn other methods of speaking later. However, they can still use this as their main speaking method or as a backup in case they encounter problems with other speaking methods. And so this is a pretty flexible way of doing it, and it's not a very normal sounding speech, but again, It's easy to learn, it's quick, and it can be used very soon postoperatively. Finally, a few older adult care points. Men in their 60s to 80th decade with a long history of smoking and heavy alcohol use are the most likely people to develop laryngeal cancer. So, a thorough assessment should always be carried out for these people when they have a prolonged cough, prolonged hoarseness, a sore throat that won't go away, little blood in their sputum, whatever. This should definitely be looked at in people of this age group who have these risk factors.